mitral stenosis, patient with mitral stenosis, anesthetic management for non-cardiac surgery. We all know that as such, rheumatic heart disease and mitral stenosis cases have come down drastically since the last 1.5 decades, but still its prevalence is reasonably high in developing countries, particularly in India. So what I am going to discuss about this, and this mitral stenosis is a commonest topic for postgraduate students for their theory as well as practical exams. So in my discussion, I'll be stressing more on points which are going to be useful for them in coming exams. So I'll be discussing under following headings like introduction, etiology, pathophysiology, disease course, clinical presentation, investigations, pre-anesthetic evaluation, anesthetic management, post-operative care, and the last, briefly, I've added a special consideration for in a pregnant patients population also. Mitral stenosis, we all know the mitral stenosis separates the left atrium from left ventricle. As such, it's an integral part of the high pressure systemic circulation. Mitral stenosis is a valvular heart disease characterized by mechanical obstruction of blood flow from left atrium to left ventricle. This obstruction is because post-rheumatic infection involving entire mitral valve apparatus, leading to thickening of the valve leaflets, thickening and fusion of cardiac tendineae, mitral annular or commissural calcification. You can see this picture showing the various parts of the mitral stenosis, anatomical parts, and the right side is a normal valve, and the extreme right side is a diseased and narrowed mitral valve. If you see the incidence, approximately 1 in 1 lakh in developed countries, whereas in developing countries like India, it was about 5.4 per thousand cases up to 1995, but it has been reduced drastically to 0.5 to 0.64 per thousand cases. Developing countries have higher rates of rheumatic fever, so the higher rates of mitral stenosis. The prevalence of mitral stenosis continues to decline because the prevalence of rheumatic fever declines. If you see the etiology, rheumatic heart disease is the commonest cause for the acquired valvular heart disease, especially for mitral stenosis. A rheumatic fever is responsible for at least about 40% of pure mitral stenosis cases. Autoimmune reaction following group A beta-lytic hemolytic streptococci is an organism for the causative agent, and females are affected more than males. The other etiology, you are all well known, like the first and foremost is a degenerative calcific mitral stenosis. This is very much predominant in developed countries and of course in elderly patients. The other causes of other etiological causes for mitral stenosis: rheumatoid arthritis, lupus erythematosus, carcinoid disease, sarcoidosis, mucopolysaccharidosis, Whipple disease. The last but not the least, the most important, whenever the students have been asked what is the differential diagnosis of mitral stenosis, is the left atrial myxoma. This is the well-known, very famous zones criteria for diagnosis of rheumatic fever, under which we have major criteria and minor criteria. Under major criteria, carditis, polyarthritis, erythema marginatum, chorea, subcutaneous nodule, and whereas minor criteria, you see the fever, arthralgia, raised ESR, CRP, previous rheumatic history of fever, first degree heart block, or a prolonged PR interval. And the criteria to diagnose the rheumatic fever, either you take 2 major criteria or one major or plus or two minor criteria. Then very important aspect of the mitral stenosis, pathophysiology. Just I wanted to concentrate all the PG students how the pathophysiology, as the disease progresses, that is responsible for all the complications. So after an attack of rheumatic fever, there is alteration of the valvular valve progresses, mostly driven by abnormal flow dynamic caused by initial, eventually repeated rheumatic insult. It's not the single episode of rheumatic infection. It is a repeated insult of the rheumatic fever causing all the pathological anatomical changes in the rheumatic valve. Rheumatic mitral stenosis, an indolent, that is slowly progressive lifelong disease that can remain latent for decades, particularly in temperate countries. So the patient can be asymptomatic as long as almost 2 to 3 decades. since the initiation of infection. So a patient will be asymptomatic for such a long time. Let us see what are the cardiac changes in rheumatic this mitral stenosis. This is I was sequentially. This slide shows a very sequential order of anatomical morphological changes since the beginning of the disease. You can see this thickening of the valvular leaflets and cusp become rigid initially, then followed by fusion of mitral commissures, and then shortening and fusion of cardiac tendineae, and all the changes leads to funnel shaped. This typical when we be reading in the UG UG period, the fish mouth appearance of the mitral valve. This is the fish mouth appearance, and finally the disease process progressing, and finally it leads to calcification, immobilize the leaflets and narrow the orifice further, altered the flow pattern due to deformity, and finally thrombus formation, arterial embolization. It may lead to in the final, the most important is the thrombus formation, embolization. The another way I try to explain the chamber-wise changes in the mitral stenosis. The first one is let us see what changes takes place in the left ventricle. Initially, to start with, obstruction to diastolic inflow. So there will be prolonged early diastolic mitral inflow and delay filling, and finally there will be decreased left ventricular end diastolic pressure and end diastolic volume. Let us see what are the changes in the left atrium. Because of obstruction to the flow, there is a constant increase in the left atrial pressure and followed by left atrial enlargement. The pulmonary hypertension leads to pulmonary congestion, and because of increased constant LA pressure and enlargement, and there's a contractile ability of the contractility of the left atrium loss, so that predisposes the atrial fibrillation, and this atrial fibrillation again predisposes the formation of, because of stasis of the blood in the LA, that leads to formation of LA thrombus. Let us see then right ventricular changes, and because there will be a right ventricular pressure overload, and this leads to right ventricular hypertrophy, and finally leads to right ventricular failure. And what changes takes place in the right atrium? Right atrial enlargement. If there is an enormous increase in the pulmonary arterial hypertension, there can be tricuspid regurgitation also. All because of RV failure, so there is increased JVP hepatic congestion takes place. A word about LV filling that is very relevant in this mitral stenosis. We all know this LV filling takes place in diastole, during diastole. Remember, in normal conditions during diastole, there is hardly any pressure gradient between the left atrium and left ventricle. It's less than 2 millimeters of mercury. This diastolic filling can be divided into two phases. One is early phase or late phase. Early phase is also known as rapid filling phase. Here, about 2/3 of the volume is filled passively. LV filling takes place passively, effortlessly, whereas in the late phase, that is 1/3, where the active contraction, atrial support is required. So there is atrial contraction is required to empty further, that known as atrial kick. But over a period of time, because loss of atrial kick due to left atrial enlargement, left atrial pressure overload, the contractile capability of left atrium is lost. So these patients are prone for atrial fibrillation. Then the grading based on the valvular area, we all are familiar. A normal valve area 4 to 6 square centimeters. It can be graded as mild, moderate, severe based on the valvular area. If you see, the mild is from 1.5 to 2.5 square centimeters. In this stage, patient is very minimal symptoms on exertion. But whereas in moderate mitral stenosis, from 1 to 1.5 square centimeters, symptoms on mild exertion, but there are no symptoms at rest. But when it comes to severe stenosis, where the valvular area is less than 1 square centimeter, even their symptoms are at rest. This is another way of grading. I would like all the PGs to concentrate. There are important parameters are considered. The severity of the disease, again, it is mild, moderate, severe. The two parameters, important parameters are considered. One is the mean transmitral pressure gradient and pulmonary arterial systolic pressure. When the mean transmitral pressure gradient is less than 5, it is mild. Between 5 and 10 is moderate, and more than 10 is severe. Whereas pulmonary arterial systolic pressure less than 30 is mild. Between 30 and 50, moderate. More than 50 is very severe. Here, I would like to mention one important point is that the patient becomes symptomatic when the valve area reduces by more than 50%. how long? See, so many years, as till the valvular area reduced by more than 50%, patient is asymptomatic. The explanation is very simple, and convenience is that normally normal patient, the blood flow across the mitral valve, the stream of blood flow, it only passes through the center of the orifice. It never occupies entire valvular area. So patient, till the valvular area reduced by more than 50%, there won't be any resistance flow across the mitral valve. That is how the patient is asymptomatic till the valvular area reduced more than 50%. There's a simple explanation is given. Then I wanted to another important point to stress is the between the mean transmitral pressure gradient versus mitral valve area. This mitral valve area, whatever the stage of the mitral valve, it is a static. There won't be change further. But whereas transmitral pressure gradient is a dynamic. Example: suppose the patient is in a moderate grading as far as the valvular area is concerned, let's say about 1 to 1.5 square centimeters. In this moderate level, if the patient is exposed to any kind of stress or increased heart rate stress, there is enormous increase in the pressure gradient. So this is a more important factor to be remembered. Even the valvular area within the normal or moderate, the pressure gradient, so that means the heart rate is very crucial in this patient to maintain. This is a well-known, based on the there's a grading based on transvalvular pressure gradient. Again, there's a well-known formula, is the oldest formula known as Garland's formula, and you have a modified Garland's. And I'm not going to discuss in detail of each component of this formula, but ultimately, what is the interpretation of this formula? See, you can see this when the heart rate is increased in a fixed small orifice, or increased in a fixed mitral orifice, the gradient across the valve increases. That means the simple equation is the transvalvular gradient is directly proportional to the heart rate. So whenever this heart rate increases, the pressure gradient increases. That leads to back pressure, LA pressure, and patient may lead and going to pulmonary edema. So heart rate is again and again is a very crucial factor. Let us see the pulmonary changes in a mitral stenosis. In early, again we have an early stage changes and late stage changes. Early changes, this pulmonary hypertension known as a passive reversible, because it's only passive elevation of the pulmonary venous and capillary pressure because of backward pressure again from the left atrium, but there is no intrinsic abnormality in the pulmonary arterial bed. But whereas as the disease progresses, in the late stage, the pulmonary arterial hypertension is irreversible. As the stenosis worsens, there will be reactive changes in the pulmonary arterial bed. That is because of arterial constriction and muscle hypertrophy. So this leads to progressive obstruction to the blood through the lungs. Due to increased pulmonary capillary pressure, that is when it's more than plasma-oncotic pressure, there will be transudation takes place and leading to interstitial edema. So then reduced lung compliance, increased work of breathing, the patient becomes symptomatic. As far as the values are concerned to diagnose the pulmonary hypertension, the pressure more than 25 millimeters of mercury in resting state you call pulmonary hypertension, whereas pressure more than 30 millimeters in stress, it is diagnosed as pulmonary hypertension. Here I would like to discuss one more important point. There is a correlation between mitral valve area and pulmonary arterial pressure. When the valvular area becomes less than 1 square centimeter, invariably you expect pulmonary arterial pressure more than 25 millimeters of mercury. Then this another important chart I would like to all the students to concentrate, that is hemodynamic changes in different stages of mitral stenosis. Here we have a, based on the mild, moderate, severe, the parameters were considered left atrial pressure, pulmonary arterial pressure, and cardiac output. Let us see what is happening in the during rest period. In mild cases, left atrial pressure, pulmonary arterial pressure, cardiac output maintains normal within the normal range. But whereas when it comes for moderate level, the left atrial pressure starts increasing, pulmonary arterial pressure increasing, and still the cardiac output maintains even in moderate stage of stenosis. But when it comes to the severe stage less than 1 square centimeter, there's enormous increase in the left atrial pressure and more increase in the pulmonary arterial pressure. Here you can see that cardiac output decreases. But when this patient exposed to exercise, Let us see what is happening. Left atrial pressure, pulmonary pressure, cardiac output increases or maintains in even mild cases. But when it comes to the moderate cases, the predominant increase in the left atrial pressure, pulmonary pressure, and still cardiac output is maintained because of compensatory mechanism. You cannot comment anything exercise with a severe pulmonary stenosis because the patient cannot tolerate exercise with a severe stenosis. Patient may collapse or patient may decompensate, and acute pulmonary edema and right ventricular failure takes place. A word about pressure volume loop. We all know it, the pressure volume loop shifts to left side. It is because of decreased left ventricular pressure, left ventricular end-diastolic pressure, and left ventricular end-diastolic volume. And then again, the students commonly been asked, what is the left ventricular, how is the left ventricular function in mitral stenosis? Yes, usually in the early stage, the left ventricular function is supposed to be normal. It should be normal, but as the disease progresses, the LV dysfunction takes place. This left ventricular mitral stenosis, as such known as a fixed cardiac output state, that is, stroke volume cannot be increased with the increased heart rate. So, for your sake of interest, the other conditions where you find this fixed cardiac output states is aortic stenosis, constrictive pericarditis, and cardiac tamponade. So how this left ventricular dysfunction takes place as the disease progresses, let us see. LV contractility function usually normal in early stages, but dysfunction in the later stages. As the stenosis worsens, flow restriction limits LV filling and preload. In addition, there is an increased afterload due to reflex vasoconstriction secondary to lower cardiac output. And LV dysfunction occurs due to LV muscle atrophy as a result of chronic underfilled state. So this left ventricle exposed to chronic underfilled state, in other terms, it will be disuse atrophy, you can say. So, and to add to that, there is a leftward shift of the interventricular septum due to RV hypertrophy that causes left ventricular outflow tract obstruction and decrease further cardiac output. Diagnosis. The most important base should be established by history taking, physical examination, and investigations. History is very important. We all know that symptoms appear gradually over the years. The first and foremost presenting symptom always dyspnea and exertion. It is secondary to congestion of the lung, and again due to increased LA pressure and pulmonary capillary pressure. Patients frequently adapt the level of functional capacity. Initially, they deny the physical inactivity initial stages, but later stages, patient may complain of fatigue, weakness due to low cardiac output. And sometimes patient can present paroxysmal cough, chest discomfort, hemoptysis, palpitation. Hemoptysis is one word. Sometimes a huge hemoptysis, the patient may collapse. It is because of bronchial arterial rupture and huge blood loss and collapse possibility. And then patient present with atrial fibrillation. Often it's on and off, paroxysmal, but eventually become chronic. And these are the commonest signs. The student will be asked, what are the commonest signs? And one more thing, yeah, precipitating factors is an important precipitating factors in the course of the disease is a pregnancy, emotional stress, infection, onset of atrial fibrillation. The patient may decompensate and become symptomatic when the patient, when the precipitating exposed to the precipitating factors. And sometimes patient may present embolic event, presenting almost 20% of cases of mitral stenosis, they can have either systemic embolization or pulmonary embolization. Systemic embolization, again, because of LA thrombus, that could be the source. And pulmonary embolism, yes, it can be there because in severe mitral stenosis, particularly right heart failure, most of the patients are bedridden. So DVT could be the source of a pulmonary embolism. And there can be abdominal discomfort due to hepatomegaly, that is a sign of RV failure. And hoarseness is seen in some cases because of left atrial enlargement, that's known as Ortner syndrome, because of recurrent laryngeal pressure on recurrent laryngeal. And this is a typical phase we call mitral phases, that is intermittent malar flush cachexia, and always there is signs of right heart failure and pulmonary hypertension dominate the examination. And cardiac examination is a very famous typical. When we were undergraduate, our teacher used to tell us how to diagnose, how the characteristic feature of mid-diastolic murmur. There's a low-pitched rumbling mid-diastolic murmur in mitral valve area, typically holodiastolic, decreasing type, no radiation, best started with a bell in left atrial position. All the low-pitched murmurs are best heard with the bell. There are two important sounds in or mitral valve replacement, but this is a common indication. I told you some severe, moderate to severe mitral stenosis when the valvular area less than 1.5 square centimeters. Symptomatic, even the valvular area more than 5, patient may need this intervention. Elderly patient, the percutaneous mitral commissurotomy is indicated. Now we have come to the most important aspect of our specialty, anesthetic management for non-cardiac surgery. Let us see what are all the principles and goals. The most important, the pre-operative assessment. Take detailed history, examine both general and systemic, assess the functional status based on your NYHA classification, and look for any patient is with AF or not, and recognition of compensatory mechanisms, whether it is how much the reserve a patient has got, whether is able to maintain a cardiac output or not, evaluate overall hemodynamic status, and presence of any comorbid disease and organ dysfunction is also important, and most important, drug history and current medication. And what is the strategy when the patient is on anticoagulants? Anticoagulants can be continued in minor surgeries when there is you expect hardly any bleeding. But in anticoagulants should be stopped 3 to 5 days before surgery for any major surgery. It should be substituted with unfractionated heparin or low molecular heparin preoperatively as a prophylactic doses. A dose of unfractionated heparin should be given 3 to 6 hours preoperatively in patient and should be restarted as soon as possible postoperatively, preferably within 12 hours. Warfarin is restarted within 24 hours postoperatively or when a patient starts taking oral intake. Remember, in emergency surgery, when there is no time, the effect of warfarin need to be neutralized with FFP along with vitamin K. Anesthetic goals. These are very important aspects of our discussion. Try mainly focus on maintaining heart rate on lower normal side, maintain adequate preload, because right ventricular dysfunction is a right ventricular dependent on preload only. So maintain adequate preload. Already LV dysfunction, the cardiac output, it will be maintained with adequate preload. So maintain afterload. There should not be any decrease in the afterload. Ensure adequate myocardial contractility, judicious use of fluids. And then I'll try to elaborate. And then what pre-medicants? Anxiolytics is very much important because it reduces anxiety, thereby tachycardia. But remember, these patients are highly sensitive to sedatives. Drugs used for heart control to be continued until on the day of surgery. And diuretic-induced hypokalemia can be detected and corrected preoperatively. Absolutely, atropine glycopyrrolate should be avoided. And analgesics, a choice of drug should be fentanyl. And in some cases, particularly in a LV dysfunction, in the major surgery, morphine could be a choice of drug. As far as general anesthetic agent are concerned, there is no single ideal agent. But remember, there is a moderate severe mitral stenosis. Generally, they have a slow circulation that prolongs the brain arm circulation. That means the onset of action is delayed in these patients. So the drugs to be given very slowly and wait till the onset, till the drug effect. So there's a delay in onset of action because of slow brain arm circulation. And the next stage, intubations of the most important is to blunt the intubation response, particularly laryngoscopy intubation. You have various drugs available. The common drug to be the choice is esmolol because of short acting, IV lignocaine. Dexmedetomidine recent time is a boon in anesthesia practice. It is everywhere, this drug. So here also it's very useful. Particularly it is very useful to blunt the intubation and extubation response. This drug also can be used intraoperatively for rate control. Volatile anesthetic to be used very cautiously, titrated dose. And the rate and rhythm, if possible, try to maintain sinus rhythm. And the goal of the rate is always try to maintain less than 70 is very critical because it allows the sufficient diastolic time for ventricular filling. Preload, I told you either to adequate normal, at least normovolemia or adequate preload to maintain. But fluid boluses bolus fluid can worsen the pulmonary edema. Remember that. should not be give a gush of blood because of hypotension. Suddenly you push a fluid, but you can find a patient landed in a pulmonary edema. Fluid should be judiciously administered to keep the right heart and PA pressure within the lower pressure range. Afterload, maintenance of afterload very crucial. Overall, our anesthetic agent, they impact on the myocardial contractility and afterload. Most of our anesthetic agent, they depress the myocardium, they decrease the systemic vascular resistance. So any decrease in afterload is catastrophe, or it will be patient can not tolerate. So it is crucial. Any decrease afterload detrimental, it can lead to severe hypotension, decreased coronary perfusion pressure also. So avoid hypoxia, hypercarbia, acidosis. It can, because it can lead increased pulmonary vascular resistance that may lead to acute right ventricular decompensation. Nitrous oxide per se, it's not a contraindication in mild cases, but cases already increase pulmonary arterial hypertension, it is better to avoid because it increases the pulmonary vascular resistance. And again, the contractility to maintain adequately. In case of LV failure, augmentation of right ventricular contractility is required because already LV is failed. So you need to have support from right ventricle to improve the right ventricular contractility, right ventricular contraction function. You may need to take the help of drugs like phosphodiesterase 3 inhibitors like amirinon, milrinone, or sometimes dobutamine may be used. Particularly when a patient is on already beta blocker, the choice between amirinon and milrinone is the milrinone with beta blocker because it causes less bradycardia that is observed. So dobutamine may be required. Either you can choose any one drugs. It's a discretion of anesthesiologist and depending upon the condition and whatever. So these are the options available. Remember, but phosphodiesterase inhibitors can reduce afterload. You should use cautiously. Special concern always increased central blood volume associated with the overtransfusion. So a down position patient cannot tolerate a down position of mitral stenosis. Take care of this now. Intraoperative hypertension can be treated with phenylephrine. Drug of choice is phenylephrine because it's a pure alpha agonist, and moreover the additional advantage of phenylephrine, it causes reflex bradycardia. That is what we wanted in mitral stenosis. The other drugs for vasopressors you can use norepinephrine or vasopressin also can be used. It all depends on the case as such. Induction agent, yes, we all know etomidate is an ideal agent because of its hemodynamic stability property. Thiopentone can be used. It's not a contraindication, but propofol, it's better to avoid propofol as it causes profound hypotension, and absolutely avoid ketamine because of its sympathetic stimulation and leading to tachycardia. Muscle relaxants, histamine releasing drugs like atracurium, cisatracurium, evacurium, tacurium better to avoid, but steroidal group like vicurium, racurium prefer relaxant. Succinylcholine is not absolute contraindication. It can be used, particularly in the case of anticipated difficulty airway, it can be used. Then overall, balanced anesthesia choice achieved with the base of the balanced anesthesia volatile anesthetic agent. Absolutely halothane to be avoided, but isoflurane, desflurane, sevoflurane can be used in titrated doses. Ensure the deep depth of anesthesia always. A goal-directed fluid therapy to be ensured. So avoid hyper and hypovolemia. And monitoring. Yes, for minor cases, asymptomatic, a simple ECG, NIBP, SpO2, ETCO2 is enough. But whereas in major surgeries, invasive monitoring like intraarterial blood pressure monitoring is recommended, particularly moderate to severe for major cases. But ideally, it should be secured before induction. And CPP monitoring, yes, it is mandatory. But remember that if there is a LV dysfunction, the CVP monitoring will not correlate what is the things happening on the left side of the heart. So when the LV function is mild or within the less than moderate level, then only the CVP is correlating. Otherwise, it will not correlate when there is a severe LV dysfunction. For that, you may need pulmonary arterial blood pressure monitoring, consider LV dysfunction. But remember, with the patient with severe pulmonary artery hypertension, this procedure itself causes the rupture of pulmonary artery and can be catastrophic. And some cases you may require continuous transesophageal echocardiography, particularly again in a major surgery where major volume shifts takes place. This is a good option where you can have a LV contractility, LV filling, and left atrium contractility is a very good option. Continuous monitoring of TE during major surgeries. Reversal, it should be achieved slowly with neostigmine glycopyrrolate to reduce the drug-induced tachycardia. Regional anesthesia, yes, absolutely there is no problem as far as the peripheral nerve blocks, and particularly US guided nowadays, it's become very popular, safe. So it's a very safe as and when wherever it is possible, go for peripheral nerve blocks. But when it comes for central neuraxial blockade, still subarachnoid block can be performed, particularly surgeries, bottom surgeries or surgeries infraumbilical or lower limb procedures in mild stenotic cases. But in moderate diseases, CSE, continuous spinal epidural anesthesia, is most recommended, graded epidural, and recently the continuous intrathecal is also an option given in these kind of cases, in even moderate cases. But remember, always a severe mitral stenosis, there is no other option, it's a general anesthesia only. Remember, for central neuraxial blockade, whenever you are planning central neuraxial blockade, patients, those who are already on beta blockers and diuretics, there can be exaggerated hypotension. Just take a note of it. And in severe mitral stenosis, absolutely subarachnoid block is contraindicated. And post-operative management, it should be very meticulous. The first 3 days is very crucial. The monitor you monitor during intraoperative is equally to be carried in the post-operative period, because there is always a risk of pulmonary edema, right heart failure continues in the post-op, so cardiovascular monitoring is obligatory. The next important factor is the pain management. The pain has to be taken. The pain management has to be taken adequate. We all know the pain increases sympathetic activity, tachycardia, and patient can land in complications like pulmonary edema, right ventricular failure. So, in some patients, you may require elective post-op mechanical ventilation, particularly with a patient with LV dysfunction already for a major thoracic abdominal surgery. So you can plan elective post-operative mechanical ventilation in some selective cases. Anticoagulation should be restarted as soon as the risk of post-operative is diminished. And the last part of my presentation, my discussion is pregnancy and MS. Just I'll briefly discuss some principles, what principles and what are the issues with pregnancy and mitral stenosis. Mitral stenosis is the commonest valvular heart disease in pregnancy, and rheumatic mitral stenosis, it amounts for about 80 to 90% of heart disease complicating pregnancy in India. So maternal cardiac complications like pulmonary edema, arrhythmia occur in 35% of pregnancy in mitral stenosis. If you see the mild, moderate, severe mitral stenosis, the complications can be from 26, 38, 68% respectively. You are all familiar with physiological changes in the pregnancy, particularly here the mitral stenosis patient, the cardiovascular physiological changes. I'm not going to discuss in detail of each factor and all, but you can see from 5th week of gestation till 32 weeks of gestation, there is continuous increase of cardiac output, stroke volume, heart rate, and oxygen consumption. But interestingly, there is a decreased systemic vascular resistance. All these factors predisposes the patient become early symptomatic, and at any point of the gestational period, the patient can have a complication like pulmonary edema, or patient becomes symptomatic. And the more awaiting complication you can see during labor, and you can see the cardiac output, all stages, particularly immediately after delivery, you can see here the cardiac output increased by more than 75 to 80%. This is where the area, the time the patient can decompensate, patient can develop pulmonary edema and left ventricular failure, acute left ventricular failure. So all stages, heart rate increases, CVP increases. And due to altered cardiovascular physiology, the patient symptomatic far earlier than non-pregnant population. So cardiac decomposition and pulmonary edema may occur at any time after second trimester. The risk of maternal death is greatest during labor. I already told the reason during immediate postoperative period. The sudden increase preload immediately after delivery because of autotransfusion of a uterine contraction that may flood the central circulation, resulting in severe pulmonary edema. So there is a continuation of autotransfusion takes place even after 24 to 70 hours of delivery. So you have to be careful about even till that time. The risk of pulmonary edema extends for several days even after delivery. So if the patient requires anticoagulants in pregnant mothers, the standard therapy during pregnancy would be subcutaneous or IV heparin up to 12 weeks, and see that APTT to maintain between 1.5 to 2.5 times normal, but warfarin to be started from 12th week to 36 weeks, maintain INR 2.5 to 3, and again subcutaneous heparin or IV after 36 weeks. Here I would like to mention one point is, now recent studies have shown better to not to use warfarin at all during pregnancy when anticoagulation required. So throughout pregnancy, when the patient require anticoagulation because of atrial fibrillation, it is only subcutaneous heparin. No more warfarin recommended as per latest guidelines are concerned. And during labor, large bolus of oxytocin should be avoided as they cause profound hypotension. Ergometrin better to avoid, and PGF2 alpha, that is carboprastal or misoprostol, to be used very cautiously. A word about during labor analgesia, the analgesia to be produced, provided with ideally CSCA, continuous spinal epidural, using intrathecal fentanyl only, intrathecal fentanyl 25 mics during first stage labor, but during second stage labor, maternal efforts to be avoided. To avoid maternal effort, therefore, second stage delivery should be cut short by instrumentation. For instrumentation, there is supplemental analgesia in the form of low dose epidural, fentanyl, or pudendal nerve block to be advocated in second stage labor. Maintenance of C-section goals is the same as a non-pregnant patient with mitral stenosis, same acceptable heart rate. But the most important point to be taken care is avoid the atrial compression and maintain the adequate SVR. Prevention of pain, hypoxia, hypercarbia, SOS is very crucial. And finally, the techniques of anesthesia, again, even for section, CSE technique is recommended, graded epidural, continuous spinal, again and again I'm stressing, there are a lot of studies, lot of cases, case reports I've seen, continuous spinal anesthesia, particularly in a mild to moderate for sections also. General anesthesia absolutely, moderate to severe mitral stenosis, general anesthesia is required. So patient should be kept in HDU, high dependent unit for 72 hours after delivery with meticulous post-op monitoring. In severe MS, where intervention is required, it is taken up during second trimester. So thank you very much for listening patiently my presentation. Thanks one and all.
Very nice presentation, Dr. Satyanarayan. You have simplified this topic very much, and probably all those PGs have taken all those points. Actually, I had the doubts in my mind, but by the end of your lecture, all those have been clarified. May I now ask any postgraduate whether to, if you have any doubts, you can send me a message or. Hello. Hello. We'll wait for 1 or 2 minutes, Dr. Satyanarayan.
Yeah. No problem. I'll wait.
Yeah. Usually we encounter cases like cesarean coming for cesarean section. Suddenly you find that the patient is having murmur on the table. Probably the surgeon has also not recognized, or it's an unbooked case which has come for surgery. They have decided for cesarean section, and on the table sometimes you find this situation. In that situation, how to go ahead? Because at that time you cannot ask for any echocardiogram or anything. If it is a booked case, then probably there is no problem. But sometimes I have encountered these cases. But probably it's the clinical. What do you suggest?
Arun.
Hello.
One second.
Hello.
One second.
Yeah.
Hello.
Hello. Can you hear me?
Yeah. Now I am hearing. Let me know the question, please.
Yeah. Sometimes in the scenario where you go to the operation theater for cesarean section and you find that the patient is having mitral stenosis or some mitral murmur is there.
Yeah.
It is an unbooked case which has come for surgery. Even the surgeon also doesn't know what is to be done. They have just decided for section. In that scenario, how to proceed for the postgraduates?
Yeah, that is the reason. At least clinical. That is what I am finding. The clinical assessment has come down drastically recent time. Ability to assess and identify the murmur, location, and at least history. What was at least the patient able to tell the history? What was the physical activity? As far as the NYHA classification, we can assess some time to some extent. So even there is a murmur. What we don't know whether it is, at least you should be able to see the systolic murmur or the diastolic murmur, whatever the murmur, based on the hemodynamic status, pulse, whether the patient, the pulse is normal, good volume, is there any irregular, at least hemodynamically stable, the lungs clear, no congestion, and pulse volume is good, hemodynamic stability is there, but still, what is they say? It is a choice. It's a chance to be taken. This intrathecal. But what they say is, if you are not aware of what exactly the lesion, it is better to go for general anesthesia rather than taking risk, because we don't know exactly. It is better to plan general anesthesia and expecting take all the precautions. See, what is a worried issue always in the general anesthesia? A sudden increased heart rate, a sudden decompression, pulmonary edema. So keep all the things ready, diuretics, and anyhow positive pressure ventilation. That is one of the important strategy for prevent the further seepage of fluid. So dobutamine is a drug, and induction, if we terminate, is see, this is what scenario we don't know exactly what is exactly condition. So take it aside, almost like mitral stenosis, but again and again hemodynamics assessment, clinical assessment is very important. If the hemodynamically stable, the pulse volume is good, and blood pressure and okay, and recent time there are no palpitation, no other things. Still, you can there is a choice between your the where you are working, the infrastructure you have, the backup you have. Either you can go with a regional low level sitting spinal. Still, if the hemodynamic stability is there, the pulse volume is good, and there is no, see, that is what a clinical ability. If you have some clinical ability, at least you're able to hear the loud second heart sound or murmur quality. Is it so is a clinical is ultimately it is very difficult in a scenario where we don't have anything. It's very difficult. That is what it is like taking a risk. So better if you don't want that, it is go for general anesthesia.
That is
Safe technique. We know that intubation response, laryngoscopy response, and all this can be there. But see that it should be maintained hemodynamic stability. Don't take any chance, even though it may be sometimes deceptive. I told you one important point. Even though there is a moderate, mild stenosis, a sudden increase or a sudden decrease. Examples: regional anesthesia, spinal anesthesia.
Right.
a sudden decrease preload and decrease systemic vascular resistance, and patient collapse on the table and increase back pressure and pulmonary edema develops. So we don't want to take any chance. If you are suspecting suspicion, better go for general anesthesia.
General anesthesia. That is good oxygenation will be there.
Yes.
Yeah.
Good oxygenation. So spinal intrathecal particularly, it will be catastrophe, and because of, I told you already, in a mitral stenosis, the only support to cardiac output maintain is a right ventricular function. How do you ensure the right ventricular function? With an adequate preload. If with a spinal, the decrease preload further, and other side decrease systemic vascular resistance, the patient can decompensate, and you have to. There's another challenge. Suddenly, patient collapses. What do? Suddenly, you try to give a gush of fluid. If it is a turn out to be a mitral stenosis, further deteriorates, and you try to increase the heart rate, atropine, and you can't take the risk. And you ergometrin, mefentermidine chloride, if that the underlying case is a mitral stenosis, again catastrophe. So best is when you don't know exactly, it is a safe is general anesthesia.
Thank you, doctor. Any other doubts? Yes. Yes, Ratnakar, you're laughing. Unmute.
Text. I think they can text the question actually. Only and all they can talk. Other text.
Right. Anything to be asked?
One thing, Dr. Deepraj, there's one more. If the time is available, you don't want to take even general anesthesia risk of intubation, extubation, graded epidural still can be an option. Graded epidural, if the time permits. If the time permits, most often emergency surgery, you all know that obstetricians will push you up. There is no time for epidural and all. There's a fetal distress and all. That is the issue. Otherwise, time permits, epidural, excellent option. Again, I told you, if you have a CSC needle available, what even cesarean section also, intrathecal 25 mics of fentanyl only, and epidural graded epidural. These are another option. So when you are down, absolutely, whether graded epidural or safe is general anesthesia.
General anesthesia. So we'll conclude, Dr. Satyanarayana. I don't see any. Can Arun see anything? Any questions on the chat?
No, sir. I can't see any questions, but the members can actually. We have given access to video as well as audio. So they can directly unmute themselves and ask the questions.
Ratnakar wants to say something.
Yeah, please, Ratnakar.
Ratnakar sir, please give access to your microphone.
Yeah.
Okay, then we'll conclude, Dr. Satyanarayan. It was a very nice to hear from you after a long time, because most of the conferences you are the main highlight for any topics. But after a long time, I'm able to. I'm listening you any lecture. It's very nice, and you have simplified the topic to the extent that even a junior postgraduate can also follow your guidelines.
That's what my aim is to target PGs. I try to cover basics, not to be seen nowadays. Clinical examination, not to be.
It was very nice, very nice.
So that's what I have stressed more on basics, and how just I've tried to make them to understand as simple as possible. Maximum I tried my level best.
Yeah, thank you, Satyanarayan. We'll conclude with this. Thank you.
Right.
Okay then. Thank you. Bye.
Arun, close the